Hello, my name is Jason Burgess, and I am the creator of Steps Insitu. I created Steps Insitu for the purpose of being able to evaluate the staff during their training for high-risk deliveries and for NRP simulations. I've noticed that while observing other instructors, there's been many different ways to teach this method, many different techniques and styles to train their staff to attending high-risk deliveries, but no real standardized way. We really don't have a way to be able to track and trend across the board our staff. Steps Insitu allows you to standardize this training throughout many instructors' different teaching styles. I'm going to go right into the program and explain a little bit about the program. So Steps Insitu is a downloadable program through the Apple Store on iOS or the Android, and it uses React Native as a programming language. The reason I chose React Native is because it is compatible with all tablets. So it is Android or iOS. Sorry, Windows, no Surface tablet creation yet. So without further ado, we'll take you right to the dashboard of Steps Insitu. You'll see here it says register or log in. First of all, you're going to log in. And I will log in with my educator account. And then when I log in here, I'm taken to a dashboard where I see the scenarios that are programmed in front of me. So these scenarios were created by me at Steps Insitu, and it's a baseline handling high-risk deliveries. At this point, I am a NICU nurse of 20 years, an NRP instructor. I've had a lot of experience going to high-risk deliveries. So I decided to use this as my first package for simulations. Eventually, I'd like to expand that into different departments, different specialties, and really grow as a simulation scenario provider. So on my second tablet, I'm going to go over here and I'm going to hit login and log in as a participant monitor. So it gives me a device number or an address, and that address will be what I would connect to my main tablet. So on my main tablet, I'm going to go link participant monitor, and as you see here, the available connections show up right in front of me, which matches my tablet. The reason that's important is right now we're just using a secondary tablet to run the program, but in the future we're going to need ways for handshaking to go on between maybe different high fidelity mannequins, some blood glucose monitors, simulation monitors. There's all kinds of things that this program can be built for it to scale to. So right now I'm going to connect with my secondary tablet. So as you can see right here on the one, it says it's paired, and what we use is Amazon's AWS network to do our cloud computing. That way, this is where currently a lot of the data communication goes, but eventually, according to my programmer, if I would like to move everything to the cloud, which is essentially what I want to do in the future, I can store all this data in the cloud, and then multiple devices, hardware devices, can grab that data from the cloud. So I could store heart rates, respiratory rates, saturation, vital signs, lab values, commands like how a mannequin would react. This can all be stored in the cloud in different parking spaces. So as you're running the simulation, it can grab this data from the cloud and essentially run your high fidelity mannequins, show you lab values, anything that you really want to do in real time, and it's all driven by the dashboard on Steps Insitu. One of the challenges I wanted to solve with Steps Insitu was how do I create synergy between two different departments? I created a simulation scenario of 25-week gestation born en route for our emergency room that would include NICU or mother-baby with a positional asphyxia. So this one would be great to run on your labor and or mother-baby units. So it will implement both your mother-baby team and NICU team. So essentially they would call for help from the NICU and continue on between two different departments. So when I selected that, I was given a little background to the simulation. I can select any of them and it gives me a little background so I can kind of help me decide what's best for the simulation team. For this, I'm going to select this and hit go. Now here I'm going to be given a chance to select which team skill level I want to use. Another challenge I wanted to overcome with Steps Insitu was how do we address different skill levels for our team? How can I create a scenario that is appropriate for our newer, more novice staff, but also challenging enough for our more senior staff? And I did this by creating team skill levels. The beginner's team skill level focuses more on the fundamentals of the NRP algorithm, whereas the advanced skill level gives you way more opportunities for a team to critically think when things don't quite go correctly. So endotracheal tube placements will be successful only half of the times. So the team needs to identify when there's a problem with airway due to a misplaced endotracheal tube. These selections also affect vital sign depreciation. So for this one, I'm going to pick beginner level just because you know what? I'm going to pick intermediate level. So this is going to give me positive chest wall movement. Majority of the time, I'm going to get more successes. I'm going to be asked to choose 3 objectives. So when I proceed, I have my objectives. I wanted the user to have the ability to continue on with the simulation until they feel that the team is able to handle any situation that they're faced with. From this list, I'm able to choose from the 6 different objectives. I can select as many as I want, but for the team skill level, it gives you a minimum of 2 for beginner, 3 for intermediate, and 4 for advanced. Advanced adding the option for pneumothorax. Once the team has met these objectives during the simulation will complete and they will be able to debrief. And what this is doing is this is telling the program, do not conclude the simulation until they've met these objectives. As an instructor, you can conclude the simulation anytime, but for this, it will automatically conclude at the end when you've selected those 3 objectives. So once I've selected my objectives, I'm going to move forward and proceed. Different organizations use different oxygen delivery methods. You can choose from the following 3. So this selection tells the program to decide if positive pressure ventilation is effective based on recommended O2 flow rates. If the participants don't turn on the oxygen flow, then they will not be able to ventilate the patient appropriately. This screen is where you'll build your team from your organization's users. This will store a lot of the data for your team so they can look up that data on their own. So they can see the debriefings of the simulation. The educators can see how many simulations are run, how are their objectives being obtained, and what level they're performing at. So it's great to give data for institutions to show to magnet status, high reliability organizations, because the reason high reliability organizations are important is this will actually also track medical errors, procedural errors. This data provides a great resource for educators to target key areas where they need to work on with their staff. You can select from a list of names from your organization, or of course, you can always start the scenario without adding any team members in case you want to do a truly in situ and just start a scenario and see which members of the team will just show up to assist. You will still be given the option to add team members at the end of the scenario. Pre-briefing screen is set up in the familiar S-bar method: situation, background, assessment, and recommendation. This is what you'll share with your team if you should choose to help set up the situation. Otherwise, you can use the cues to set up your simulation in the way you see fit. For example, you might want to tell a mother-baby nurse that she's going to walk into a room which is set up with her patient that's had a baby and hasn't really slept for 24 hours. You'll arrange to have somebody in bed sleeping with a patient on her chest. This will set you up for your positional asphyxia, and you can just start the scenario and follow the team along and see what they do from start to finish. Next team comes in. You pre-briefed that team on NICU. This is very early, so it hasn't been fully exercised in organizations, so it can always be used to provide, I can get feedback and kind of alter things to make it better. Little background about the mom, little things that will actually help cue your team in. So we're going to proceed, and this takes you to the dashboard. So the dashboard here, Um, this is what the instructor will be controlling things from. And as you notice on the secondary monitor, it's already linked up with their bedside monitor. Bidirectional data communication means what settings the team turns on their oxygen settings will directly affect the outcomes for the patient, and these all happen in real time. This will further encourage critical thinking as the team will need to turn on the oxygen from their monitor. We're ready to go. The team is ready. They prepared what they needed, and we start the scenario. So when the team arrives, the infant is limp, dusky, and apneic with minimal responses to intervention. What I do here at this point is I tell them that information, and then I watch them react on the mannequin. So the mannequin, it can be a high fidelity simulator, which you could probably have a simulation specialist controlling the heart rate to match the heart rate of the monitor. Ideally, I would love to be able to coordinate with like Gamard, CAE, Laerdal, and be able to bring this to them. I have a pause button here, so I'm going to hit the pause button right now while I explain it a little bit better. So imagine if you had a mannequin that normally, traditionally, you would be running with a heart rate and you had to dial in the different phases, and it's all done in real time, and you're trying to maintain as much realism as possible. You want to be able to dial in the data they want, respond to the team as they're doing actions, and have the end result of the heart rate, the respiratory rate, any kind of outcomes happen pretty much on the fly, because sometimes teams don't always perform to the level you want them to perform at. So to be able to do that, it takes a highly skilled simulationist. And let's face it, right now, finding staff to keep the hospitals running is hard enough challenge. So having a simulationist, not a lot of hospitals are fortunate enough to have a simulation professional to run the simulations. I want to have the option to be able to put this device in the hands of an educator and allow them to train their staff whenever it's convenient for everybody. And wouldn't it be cool if we could actually link up with some of these high fidelity mannequins, be able to run our simulations in real time? Just set up, link up, and go. So we'll continue on. I'll hit the play, and I see the team come in, and the first thing they do is put the stethoscope on the baby's chest. So I hit the stethoscope button. This tells me that the heart rate is 50, and if you look on theirs, the heart rate is 50, and there's no audible lung sounds. The chest assessment shows up. Notice the heart rate just went away there. That's because a heart rate does not stay stationary. If I hit it again, it will change. Or actually, this one, it didn't. So first thing they're going to do is positive pressure ventilation. You administer positive pressure ventilation and see chest wall movement. The infant's tone appears slightly better, and somebody brings in a monitor and puts the monitor on the patient. So I hit the monitor button. Now I have an EKG on the monitor here. So it's giving me a heart rate and a saturation rate. At this point, they're given positive pressure ventilation, and they're stimulating and trying to get the baby to breathe, and they're going to listen to the chest. Lung sounds are equal with positive pressure ventilation. Our heart rate is now less than 58. That would cue the team to start chest compressions, because actually they have a choice here. They can start chest compressions, or they can get an established airway, which would be intubation. It's up to the team, because do we intubate for a stable airway? Probably. If you take the NRP algorithm, that's what we should be doing here. So for this one, we're going to intubate. And if you see here, there are steps to intubation. So I'm watching them perform these different steps. And the second monitor, the heart rate and the saturations continue. So I'm watching them, and we didn't provide PPVs between attempts because we were only attempting once. Now the computer is going to program and say, oh, this was successful. So you do see color change on the CO2 detector because I did select that they use the CO2 detector. But if you don't select that, it won't tell you if you see color change on the CO2 detector. Lung sounds are clear bilaterally. Our heart rate is greater than 74, but our saturation is low. So the team decides, let's turn up our oxygen. we're going to go up to 50%. And with that, we see an instant increase on our oxygen saturations. So we're doing great here. We have intubation. We should probably give this child some fluid. So they're going to need to put a umbilical line in. And this, every facility does things similar, but sometimes a little different. So based on your unit's policies, you would select either that they were placed per protocol or were not and needs review. Now we've placed the umbilical line and there's positive blood flashback. So we are successfully in, and we can now continue on with the scenario. Our heart rate is 68, saturations are 61, we're at 50% oxygen, and we're not really doing that great. So what I'm going to do is I'm going to tell the team, all right, I need to perform, we need a saline bolus. So prepare the saline bolus. So while they're preparing it, you can see that the heart rate is now falling, and it's falling below 60, which will prompt us to start chest compressions. So start chest compressions while we're waiting for that saline bolus. Also, I would call, as a lead, I would probably call, we also need you to prepare epinephrine. And as an instructor, because I don't have to focus on how to respond to each action the team gives, I can focus on things like team dynamics and communication. So I can give them appropriate feedback. So after I receive the saline bolus, I'm going to administer it. So what, if you notice here, I'm going to take it back here. You notice that the heart rate and the saturation rate did go away. Well, realistically, while you're performing chest compressions, you don't get an accurate reading on a monitor or a sat probe reader because a lot of times there's a lot of motion. So we chose to hide the heart rate and the saturation rate in order to encourage realism during procedures. So we're going to administer that saline bolus. And it's asking me, this is the correct dose based on this weight that we have for our patient. Is this the correct dose? Yes, they selected the correct dose. So that saline is going, and you notice here there's a little button that says stop saline bolus. That's because this is also timed. Saline boluses should not be given rapidly. It's not helpful. It can cause brain hemorrhages. You're supposed to give it over 5 to 10 minutes. And this will track that time. So remember when I said procedural errors? Well, this is one of those that can track for that. So if you say you gave saline bolus really quickly, yes, you'll get your response in your heart rate and your saturation rate, but it will also mark it as, hey, we need to review this because you're giving it too quickly. So at this point, we're going to stop chest compressions. We're going to look, our heart rate is still hovering like around 64, saturations are low. We need to actually go up on our oxygen because go to 100%. And we did have a response. Our heart rate and our saturation did respond to that oxygen. So there's a good chance that this is more respiratory driven. As we're given that saline bolus, we also have a lot more stability. And let's just stop this saline bolus. Perfusion is slowly improved during the course of this bolus. Minimal respiratory effort is there, and let me listen. Lung sounds are faint on the left side and absent on the right. So this makes me think that maybe we have a pneumo, possibly. Faint on the left, absent on the right. So let's transilluminate the chest. So the transillumination reveals minimal radiance of light. Skin color is dusky. Infant has a minimal tone. So I'm also not happy with the way the heart rate and the saturations are. You know what? Let's reintubate. So I can reposition the tube or I can reintubate. Let's reintubate. And as you can see, I'm going to not use a CO2 detector just so I can show you. And listening for the heart rate bilaterally, they didn't do that either. They just put the tube in. So if I look, now I will just see the transillumination that it's the same as before. I don't see any skin color still dusky. Heart rate is less. Wow. So let's start these chest compressions and let's administer epinephrine. Where do you want to administer it? Endotracheal tube or the umbilical vein. So this one we have a UV, so we're going to give it in the UV. And this asks us, is this the correct dose? So 0.3 to 0.9. Yes, this is the correct dose. Infant's tone improves and the vital signs improve. Infant color and perfusion improve. This is wonderful. This baby, if I listen, our heart rate and saturations have improved. We are recovered. So let's end the scenario and debrief. Oh, before I do that, let's do one thing. Let's pause. And there's a little undo button here. I want to talk about the undo button just for a minute. So the undo button is used for, let's say the team goes way off track and they're making decisions that are ill-advised decisions. And you notice as an instructor, we need to stop and back up. And traditionally you would say, okay, let's pause everything. Let's talk about things and then maybe start over. But for this program, what we can do is we can undo steps. So let's say we did that. Let's undo that. We transilluminated. This is before we gave epinephrine. Let's undo another one. And notice the time back steps. And let's resume. So this is where we transilluminated. We are going to administer epinephrine. Instead of doing chest compressions, let's give epinephrine. There is minimal respiratory effort. Let's listen. Lung sounds are faint bilaterally. Let's reintubate. And the computer will randomize whether we're successful based on our team skill level. Some movement, minimal respiratory effort. So there is lung sounds are faint. Okay, so we have chest compressions we can do. One more thing I do want to talk about also is the challenge button. So let's say the team is doing very well. They're actually acing everything and they're making it look too easy. Well, there's a button here that says challenge button. When I press that challenge button, the baby will decompensate. And as you can see, that will kind of move things along. And now that the team notices the heart rate is low, they're going to start chest compressions. So when a baby decompensates, they have to ask themselves, are we intubated? Do we need to reassess things? What should we do next? And for this one, we're going to administer epinephrine, umbilical vein, give. Yes, this is the correct dose. And now we're back to the point where we were before. So we have stabilized the patient. We'll end the scenario. Yes, you're done. And we finish that scenario. So we have the team here. Let's say more members came to the scenario when we hit the staff assist button. We can add the members here. So I'm going to add myself and a mother baby nurse. Finish adding team members. Now we have 6 people. So this team has grown. And as you can see here, this is a summary. So for debriefing, it's important to talk about everything that happened. And I couldn't possibly remember everything that happened. So this is going to help me with a debriefing. There is so much learning that can be had from debriefings that I figured this would be the most integral part of this program. So I had the program record every action the team makes along with every vital sign that happens during that action, all time-stamped and organized. So the instructor can properly debrief with the team. Say they missed a step, they can go over it again with the team, or even a procedure. They can also discuss this. We can also see where I paused here at 8:17 and undid some actions. They're still there, so we can talk about them, but I backed up a few steps so it will take over from where we were. And then here you see challenge activated. So you continue on here and continue through. So at the end of the scenario, what I can do is I can send a copy to the educator for review. And that will send an email to the educator saying, hey, click on this link to review this debriefing. You don't have to. I can retake the scenario, or I can save and return to the dashboard. So when you click save and submit, each member will be able to log into their personal accounts on stepsinsitu.com and view their own debriefing reports, which we'll be showing you very shortly in this demo. And what we'll do now is we'll go over to the dashboard. So I go to stepsinsitu.com and I'm going to sign in with my educator account, which is right here already. Log in, and that takes me to my dashboard. If you notice here on the dashboard, I have how many scenarios the Academy has performed, how my subscription limit, and how many users are signed into the Academy. I'm also seeing how many high-risk deliveries were done, how many times they were completed. I can see percentage, so as my institution gets better, I should see more advanced, less intermediate, and much less beginner skill levels. So I can track and trend that on dates and times. So I can go here, so October to today, I can apply that and see that this is run advanced times 1. I can see how many departments are utilizing my program. I can see the history, and I can actually see today's debriefing. So 12/9, that's what the day I'm running this. I click here, I'll see the scenario, can see the objectives, and each of the team members can also see the objectives when they log in. They can see everything that I see right here. Who was there, the scenario, the debriefing, everything was there. Okay? And I can also, if I had a question about something, I can also forward this report to the educator. So as you can see, this program closes the loop of communication between the staff and the institution and the educator. So it encourages open communication between the institution. And can you imagine what the future could hold for this program? So this has been a demo. I know it's a little bit lengthy, but it does show what Steps Insitu is currently doing and future plans for Steps Insitu. I would love to be able to control a more in-depth simulation. So have histories that patients can look up, x-rays from the history. In the adult world, we can have a whole medical chart pretty much programmed in so they can look up lab values, running iStat machines, simulation iStat machines that will pull up lab values, radiology, x-rays. You can order medications. This was just showing 2 medications, epinephrine and saline boluses, but you could do so many things with this program. And because the power of the computing, you can also have medications interact with other things. So let's say epinephrine. You give an epinephrine, it would require possibly more oxygen requirements based on cardiac output. So yeah, your heart's beating faster, so then the oxygen requirements might go up. So it can calculate that based on your team skill level. So that side effect can happen more frequently for the more advanced team skill levels. Medications can have timed responses. So if you give a certain medication that doesn't act immediately and has maybe a 5-minute before it becomes effective, you can program the computer to do that. Or if it's a rapid acting and it only lasts a couple minutes, you can also program the program to wear off the medication within that time limit. You give 2 medications that are not compatible, or you have a medication that you give too rapidly that will cause chest wall rigidity. Well, the program can calculate all that and show that. If you give a lot of saline, that can also calculate in, and if you draw a lab, after you give a lot of sodium, you can see an elevated sodium level. Same goes for glucose. If you give a glucose bolus and the program will count down, that glucose will spike. So the program will say, if glucose given, then add 50 points to the blood sugar. Well, if you already have high blood sugar, you could be in a bad shape. So it can really simulate the patient and the patient's responses to actions. So what we're trying to go for here is we're not trying to program like a simulation program. We're trying to do like a patient simulator per se, and see how the teams respond to it. That way it can open up that debriefing and educate the team, allow them to make mistakes in a simulated environment, which is the only environment you want to make mistakes in, and you want to encourage that challenge. So that's about it. That's my program. I hope you like it, and I hope you can see some potential in what this program can do. Currently, we have released this first release. I released it last year, fine-tuned it, and I pretty much hit the end of the line where I can really grow this program. Hopefully, with enough support from other members out there, I can continue to work on it with teams, without teams, for institutions. But I need that support from you guys. So, once again, this is Jason Burgess, the creator of Steps Insitu. And you can reach me at jason@stepsinsitu.com, or you can go to the website and send me a message through there. Thank you so much. And the first simulation is available. You can reach out to me if you want me to open up the academy and add you to the academy. You know how to reach me. Thank you once again, and have a wonderful evening.